You are good to go.
Okay, let's see if I can find the right window.
That looks perfect. We can see your screen.
Okay. So everyone who's on the phone, thank you for joining. Many of you have heard of the Interact program and maybe have used components of it. And I'm going to give you an overview from my perspective. I've been involved in developing and evaluating it since about 2007. So that's a long time now. I'll ask at the start, is there anyone that has specific questions? I want to make sure I address what you're interested in. So let me give you an opportunity to ask specific questions now, and I'll try and address those. Anyone, and you can always interrupt me by unmuting yourself and asking a question. I don't mind that. Does anyone have a issue they specifically want me to address? Don't be shy. I find long-term care participants very shy. Most are very shy.
People can also post questions in the chat. And
Oh, there's Dr. Simmons.
Joe, Isaac, and I can keep an eye on the chat for you.
Okay, good. You don't like to speak? That's good. Okay. So we're going to review Interact program, which is a quality improvement program that was designed primarily to reduce unnecessary hospitalizations and hospital readmissions of older nursing home patients and residents. I'm going to describe the outcomes of some of the evaluations of the program implementation. And then I'm going to discuss some strategies for efficient and effective implementation of programs like this in practice. And I think this program, I know your coalition has been addressing COVID-19, and I think this program has lots of applicability to COVID and other similar outbreaks in nursing facilities. So Interact was originally designed for nursing homes, but can be adapted to assisted living facilities and home care. And if you look on the website, you can find tools that have been adapted. They have been evaluated as well, but they are there. I have disclosures. I have been fortunate with the team I work with to receive funding from several private and federal sources to develop and evaluate Interact. Pathway Health, which is based in Minnesota, now has the exclusive license to provide education and sub-license Interact program to software vendors and others. And I receive royalties. My wife and I receive royalties, and I serve as a paid advisor to Pathway. And all of this has been worked out meticulously with conflict of interest management plans that were developed by the FAU Financial Conflict of Interest Committee. It wasn't easy because I was probably the first person at FAU that went through this kind of process. So emergency department visits, transfers from the nursing home, observation stays, hospitalizations, and readmissions are common. We all know they result in complications and they're expensive. This is data from 2010, and it's maybe a little bit different now, but it's not dramatically different. And what this shows is is the variability in hospital readmission rates across the country. So you could see it at this time. It ranged from 15% in low transfer facilities up to 30%, and the range is actually much greater than that. There are some facilities now. Some of the facilities I work with have transfer rates below 10%. And some facilities, especially for some conditions, have transfer rates above 30%. So it's still highly variable. So we have work to do. In terms of emergency department visits, there are about 3 million emergency department visits per year per nursing home bed. So that means about 2 emergency department visits per occupied bed. And a study examined approximately 14 million of these ED visits over several years. And over half of those did not result in hospitalization, although clinical experience shows that if you send a nursing home patient to the hospital, they're very likely to get admitted. In this study, it was just about half, and a substantial proportion of these transfers could have been avoided. And not only they could have been avoided, but when charts were examined, 63% of these nursing home patients who went to the emergency department had normal vital signs, and 19% didn't have a diagnostic test. And on the other hand, close to 10% were exposed to potential harm, such as a bladder catheterization or prescription of a CNS active medication. So does anyone want, why would a nursing home patient go to the hospital and be found to have normal vital signs and not have a diagnostic test? Can anybody figure that out?
Could it be after a fall? Maybe it's like kind of routine care to have them go to the emergency department.
So you're cheating. You wanted somebody from the nursing home to answer it. Yeah, I think it's mostly false. We can talk in detail about fall protocols. Not every person who falls needs to go to the emergency department. They can be observed if they meet certain criteria. So I think that's probably right, Isaac. So these transfers cause distress and discomfort for the patient, resident, and family. There's considerable time and effort on the part of nursing home staff for evaluations and documentation, which many of you know. And many of you also recognize that when the patient comes back, they've suffered often from delirium, polypharmacy, falls, incontinence, catheter use, infections, undernutrition, and weight loss, and especially immobility, deconditioning, and pressure injuries. When I was in the hospital last year, the hospital, and then the nursing facility where I work, after back surgery, I got so deconditioned in about 10 to 12 days. I'm still doing physical therapy from that. And the delirium is very common. I was on rounds with trainees on Friday, and we saw this patient who had gone in the hospital with altered mental status, and it was probably alcohol withdrawal, which is relatively uncommon in older people, but he's a known drinker. And he came back, and he was not, I don't think he was given the appropriate medication, and we saw him and he was just delirious. He wasn't as bad when one of the trainees saw him earlier in the day, but when I saw him, he It was hard to talk to him. His speech was disorganized. He was hallucinating. He simulated having a drink. I mean, it was unbelievable. I've never seen a patient do this, where he was kind of sleepy, and he picked up a bottle, poured it into the glass, and took a sip, and there was nothing there. I've never seen that. And so delirium is associated with a whole number of other complications. So we don't want to send people to the hospital and have a high incidence of delirium when they don't need to be sent. And we know that if clinicians, expert clinicians, review charts, that they rate a substantial proportion of these admissions and readmissions and observation stays avoidable or preventable or unnecessary. In fact, about a quarter to 2/3 of them might be unnecessary, depending on which study you look at and how the evaluation was done and how avoidable or preventable was defined. But that's a lot. So we did a study, kind of a database study. I was asked to work with CMS, and we did it on dually eligible Medicaid beneficiaries. And it was about 1 million hospitalizations. And we did this by rating diagnoses as potentially avoidable. And there are real pitfalls with that. I'll be happy to discuss. But we found that about 40% were associated with a diagnosis that was considered potentially avoidable. And that cost in 2005 dollars was $3 billion. So that's a lot of money. We also did what's called a sensitivity analysis. So for example, not every patient that goes to the hospital with heart failure that hospitalization can be avoided. So we made some assumptions about whether 20% could really be avoided in real life, or 60% could be avoided in real life. And it's still related, it still came out to tens of thousands of hospitalizations and about $2 billion in expenditures. So it's very expensive. And so if you think about it, what are we doing sending nursing home patients to the hospital when they don't have to go, creating potential harm and spending so much money? It just makes no sense. It's never made sense to me. And many of you, I don't know how many of you work in a value-based care kind of environment, but we all have, there's pay for performance, incentives for quality. There's no payment for certain complications. There's Medicare managed care, which more and more people are being pushed into by the federal government. Accountable care organizations, bundling of payments, and other programs. I work for an ISNP, an institutional needs program. It is kind of a version 2 of the Evercare program, or version 3 of the Evercare program from United Health or Optum and PACE programs. So there's going to be an evolution of value-based care over time. Right now, about 60% or so of Medicare beneficiaries are still in a fee-for-service system where there are incentives to send people to the hospital, financial incentives. But I think that's going to continue to change over time. So that's kind of the background. Now I'm going to describe the INTERACT program. The purpose of the INTERACT program is to improve care of nursing home patients with acute changes in condition. Okay, so you can have quality improvement programs that address a number of different conditions. This one is focused on management of acute changes in condition. The program and all the tools are available for free for educational and clinical use at the web address shown there. For those facilities that use point-click care, some of the program is available in point-click care. We're trying to work with them to embed Interact in a more effective and efficient way, and I'll talk a little bit more about that later. So even though I'm called the grandfather of Interact, I don't know why they call me the grandfather of Interact, but there are many people who have contributed, including Sandy Simmons. This is kind of a list of our team here at FAU, and there's 2 nurse practitioners pictured with me. Many years ago now, we did an Interact Institute, and we presented to, I think there were over 200 people there. So again, this program is free at the website. And there are several strategies that have been incorporated into the Interact program. So the first is to prevent nursing home patients from having conditions that become severe enough to require hospitalization through early identification and evaluation of changes in condition. So those changes might be subtle: a slight decrease in appetite, not drinking as much fluid, alteration in mental status, that are non-specific. But because in many facilities, different direct care providers take care of people, they don't necessarily notice them. The second strategy is to manage some conditions without transfer. When we review cases, and I'll talk a little bit about that, we find that there are things like a cough and a low-grade fever. Not everybody with a cough and a fever needs to go to the hospital. It can be managed effectively, and sometimes more effectively, in the facility rather than in the hospital. A third strategy is to improve advanced care planning. Many of the hospitalizations that are rated as potentially avoidable are because people are being sent back and forth to the hospital for futile care. And I understand a lot of this may be related to the families, but I have my own way of dealing with that, and everybody does. It's not easy, but if somebody's going back and forth to the hospital repeatedly, they really need to consider end of life or comfort care at home. And I'm sure all of you know that Jimmy Carter just made that exact decision. Fourth strategy is to improve communication and documentation. That means within the facility as well as between the facility and hospitals and home care programs. The program has to be part of ongoing QI initiatives. It can't be separate. So whatever quality improvement programs you have going on, it has to be one of those programs given some priority. You can combine Interact with other care transition interventions. For example, having a discharge process from the nursing home to home, and creating a transitional care program around that. And then last, all of these programs, I believe, need to be embedded in health information technology in a way that's easy for providers to use. So I spent a long time trying to revise this slide. I hope it'll work properly. It may not. But this is an overview of the Interact Quality Improvement Program. And there are a whole set of tools. There are actually about 30 tools. If you look on the website, there are communication tools, there are advanced care planning tools, decision support tools, and quality improvement tools. And the way this, we envision putting this together as a program and not just a set of tools is it starts at admission. So a new resident is admitted or readmitted. Sometime close to admission, doesn't have to be in the first hour, depending on the person's condition, advanced care planning needs to be addressed and documented. MedRec is unbelievably important. I remember when I was transferred from the hospital where we were working to the skilled nursing facility where I was working with the nurse practitioner I work with, and they couldn't even get the MedRec straight on my MedRec. It was, and it wasn't that complicated. So it's easy for that to go wrong. And then the core of the program is based on when there's a change in resident or patient status. It can be noted by a nursing assistant, other direct care staff, dietary staff, housekeeping staff, or the families often notice changes. And we have a tool for that called a stop and watch early warning tool to document the change and communicate it. And that should be communicated to a licensed nurse who can elect to do an evaluation if they think that's warranted. And while they're doing the evaluation, we have decision support tools. We have Care Pass and acute condition guidance, and they're originally made in file cards. That's very specific about when to notify a clinician immediately. And generally, a clinician is notified, and we have an SBAR form and progress note that documents the encounter. Now, this is not something that is meant to be filled out after the person goes to the hospital. That's not what the purpose is. The purpose is to document the change, the evaluation that's been done, and to communicate it effectively to the clinician, okay, so that a transfer can be avoided. It's not a tool to use after the transfer has already occurred. And then we have, if the person has to go to a hospital, we have communication tools to send the patient to the hospital and back and forth. And then there's a quality improvement component of the program where you can track hospitalizations, you can do quality improvement reviews, root cause analyses, I'll show you. And then you can learn from those and improve care processes and education based on what you learn. So I'll show you some of the program. Some of you may be familiar with this stop and watch early warning tool. It was designed for an 8th grade reading level, and it can be used for nursing assistants, other direct care staff, therapists, and families to document the change that they've seen. Verbal documentation. I have some videos that illustrate some of these points, but there's not enough time to show them. But it shows how, for example, this kind of information can be verbally communicated between a CNA and a licensed nurse, and then it's kind of forgotten about. I mean, if my wife tells me something to do, she knows. She doesn't even ask. She knows that if it's not written down, I won't remember. So this is a tool to help not only document a change, but to remember to evaluate it. And then there's an S-bar communication in progress note. This is supposed to substitute for a nursing change in condition note. It is not an add-on, it's a substitute. And it has some recommendations about before calling the clinician, what you should do. There's nothing more frustrating for a clinician if a nurse calls them from the facility and there's no vital signs, the record isn't available to say what medications they're on or what diagnosis they have. It puts the clinician in a very awkward, frustrating position. Many nurses have felt that this evaluation is too long, but many others have looked at it and said, yes, this is appropriate. It's well within the scope of what a licensed nurse should do in a nursing home. It's an unfolding evaluation, meaning that you don't have to do it all. There's decision support from our care paths and change in condition guidance built into it. And the way it's operationalized on point-click care is that you don't see all these questions. You only see the questions that you need to answer. And we're going to be refining that, hopefully, over time. So, for example, if the change in condition is blood in the urine or pain with urination, a detailed lung exam is probably totally irrelevant to that change in condition. So you may elect to not do that and document that it wasn't clinically indicated. So I mentioned we have care paths. We worked hard on these. They're not perfect, but they address 10 of the most common conditions that result in transfer from the nursing home to the hospital, including the ones listed there. And you can see on this care path that all the care paths are kind of structured the same way. There's a definition of what the change is. Always take vital signs. I'm a huge believer in vital signs, even though we know that older people may not have abnormal vital signs and be sick. There's vital signs criteria. Those criteria are not fixed in stone, but I think they're clinically reasonable. Many would argue with some of them, but that's okay. And then there's an evaluation. If the person doesn't need to go right to the hospital, there's an evaluation for symptoms and signs that might require immediate notification of the clinician. And then notification of the clinician may be appropriate to order some diagnostic tests. And if after that, the nurses and the physician don't think the transfer is necessary, there are recommendations for managing the person in the facility and monitoring the response. So again, these care paths they're pretty general. Some of the things are specific, but and they're not perfect. But what happens often is you can't tell what was done. And if you've ever served as an expert reviewer in a legal case, if it isn't documented, it wasn't done. So the SBAR really helps you document that you went through a systematic process. If the person has to go to the hospital, we have a transfer checklist that can be taped onto an envelope of what documents should go to the emergency department. When we first did focus groups with emergency department staff, they said we really don't get adequate information. And what they meant by that was they meant one of two things. One, they got one page and it said AMS on it. That's all it said, AMS, altered mental status. And that's inadequate. The other thing that sometimes will happen is the nursing home copies everything. And busy emergency department physicians and nurses are not going to go through a stack of 100 pages. They're just not going to do that. So only selected documents should be sent, and there's a checklist of information that should be sent immediately or in the next working day. So this is an example of a transfer form. I know the state of Florida has adapted some of the elements of this, but it is what emergency department physicians and nurses say they need to make an informed decision about a nursing home resident, because most of them have never stepped in a nursing home and they don't know you. And vice versa. This is a data list that should come back from the hospital. This was developed by a panel of nursing home providers, mostly in Florida. This is a checklist of what nursing home providers think they need from the hospital. And then there's a spot for critical information that comes back. I could give you numerous examples of that. One of the things we run into often is that person comes back from the hospital, they're anemic after a fracture and surgery, or they have chronic kidney disease and they're anemic. And when they get admitted back to the nursing home, somebody orders a CBC and their hemoglobin comes back at 7.2. And then the nurse calls an on-call clinician and they say, oh my gosh, 7.2 hemoglobin, send them back to the hospital, when it was known already that the hemoglobin was 7.2. And something other than an emergency department visit and hospitalization for blood transfusion could have been done. There's no substitute for talking to someone. It's very, very important. Sometimes it's hard to get in touch with each other. But there are secure communication systems that can be utilized to give a warm handoff, a person-to-person handoff. So I talked a little bit about the importance of advanced care planning in trying to prevent unnecessary hospitalizations. And Interact has some advanced care planning tools that you can look at. Many other organizations do as well. On the Interact website, there are links to those organizations. I'm going to present a patient to you. And if you've heard me present this, that's okay. But this is a real case of advanced care planning gone wrong. It's a 93-year-old living with son and daughter-in-law and had progressive multi-infarct dementia. She was a former licensed practical nurse who did not want CPR or other intensive end-of-life care. And she had filled out a yellow DNR form. I don't know if that's necessary in Tennessee. I can't remember, but in Florida, if you don't have a yellow DNR form, the paramedics will perform CPR. She fell and fractured her hip, and her DNR form was lost on the way to the hospital. So this woman, former health professional, was admitted to the hospital at risk for having CPR. performed on her because her form was lost. And then when she went from the hospital to the nursing home, another form was completed and it was lost. And she was admitted to the nursing home on full code status when she didn't want that. So that was my mother. That happened to my mother here in Boca Raton. And I can tell you that if my mother, she worked as an LP until she was 90, my mother went through CPR and had broken ribs and ended up on a respirator because her DNR forms were lost. That wouldn't have been okay with me. So I'm not sure what you need to do this effectively. I don't think everyone needs a tattoo with their advance directive on it. Like this person, this is a real picture from the New England Journal of Medicine. We have an advanced care planning tracking form to document discussions and to document decisions. And something like this should be used. In over 10 years of working with point-click care, I've been unable to convince them to put something like this into point-click care, but still going to work on it. So we do have a tool to document advanced care planning. And I mentioned another component of the program is quality improvement. To review what's happened, to do a root cause analysis, and try and learn from that, and provide education. So this is the quality improvement tool, and it's five parts, and the last part asks, in retrospect, does your team think this transfer might have been prevented? No or yes, and describe why. And then there are a list of things that are the common things that we have found that providers mention, like the symptoms could have been detected earlier, the symptoms could have been managed in the nursing home, the advanced directives weren't in place, they were discharged from the hospital too sick. So if the transfer was rated as potentially preventable, we documented the main reason. So we found out some interesting things. This was based on close to 5,000 transfers in many different nursing homes. You know, providers will say, "Oh, all these transfers occur at night. It's all when the evening and night shift is on." Well, and on the weekend. Well, we found that the percentage of transfers that occurred on the weekend from these forms, now these were supposed to be randomly selected forms, was 23%. So not all the transfers did occur on the weekend. And in terms of time of day, staff will say, well, they all occur in the evening and night. And that wasn't true. Only about a third occurred in the evening and night. So the point of me showing you this is that impressions of what's going on are not as good as data. Looking at the data. Days since nursing home, since admission to the nursing home of a transfer. So we found that 22% of the transfers occurred within 6 days. Now, again, other studies have shown that more occur in the first week, but regardless, that's a substantial number of transfers that occur just a few days after coming back from the hospital. And you got to think that something went wrong in the transfer. We did this. This number is based on 4,400 transfers, but we've actually done this on close to 7,000 transfers, and we've asked, the question about, in retrospect, do you think this transfer could have been avoided, or was preventable, or was unnecessary? And it was very consistent. Between 22 and 24% of the transfers were rated by nursing home staff as potentially preventable. Why? A quarter of them, changes could have been detected earlier. The conditions of 40%. Now, these are not mutually exclusive, so they don't add up to 100. 40% could have been managed with available resources. And a third, 28%, were related to advanced care planning. We found that it was very interesting to look at these data, and it reinforced what we were trying to focus on in the program. Now, what about the effectiveness of the program? So the first study that we did was a sample of nursing homes in 3 states funded by the Commonwealth Fund. It was in New York, Florida, and Massachusetts. And it wasn't a randomized trial. We divided the homes up into those nursing homes that were engaged and not engaged without knowing their hospitalization rates. And we looked at their hospitalization rates over 6 months, the same 6 months in the baseline year and the intervention year. And this was done in about 2010. And we found that the engaged nursing homes had a 24% reduction in hospitalizations. That's huge. That's a lot of hospitalizations, enough so that the net savings were close to $120,000 per facility. Then we did a very large randomized trial of implementation of the Interact program. We used several strategies in this program, including distance learning training that was developed by Sandy, and repeated webinars, feedback of data, case discussions. We did a lot. There were too many nursing homes in the study to travel to each of them. There were 264 nursing homes. And we reported data on 85 nursing homes with no prior use of Interact, because the study was contaminated because a lot of the facilities started using Interact when they were in the control group. And overall, if you adjust for multiple comparisons, there was not a significant effect. But if you look at potentially avoidable hospitalizations, there was about a 15% reduction in potentially avoidable hospitalizations in this large study. I don't expect you to see data necessarily here, but what these data that we published showed that the greater change in Interact implementation during the study, the greater the reduction in hospitalization. So increased use of the core tools of Interact was associated with an higher reduction in avoidable hospitalizations. And these are graphs you teach trainees not to show. Nobody can read all these graphs. I don't expect you to read all these graphs, but I'll summarize them by saying that we were concerned about safety, because if you're trying to manage sicker people in the facility, you may have complications, a variety of complications. And we had a data safety monitoring board. And what these data show is that we found no increase in self-reported complications like falls, new pressure ulcers, severe pain, dehydration, weight loss. And we couldn't do this using the MDS because at the time it took 1.5 years to get the MDS data. So we had to do this by calling the facilities and getting self-report on their data. So there was no adverse effects of implementing the program. So the program was used in a CMS-funded project that occurred in 7 sites, multiple nursing homes, about 150 nursing homes in this study. All of them used some components of the Interact program. And there was, again, a significant reduction in the probability of all-cause hospitalizations and the probability of potentially avoidable hospitalizations in that study. This is probably the best example of Interact implementation. This was one of the sites in the CMS project in Missouri, led by Marilyn Rance. And what they did is they utilized nurse practitioners, advanced practice clinicians, to train staff on the Interact program, elements of the Interact program, to serve as champions for implementation and to help evaluate changes in condition. And during the course of this study, they had a 30% reduction in all-cause hospitalizations. That's an enormous effect. So I think this is the way we would envision optimally implementing the Interact program. It does require extra staff. It was grant-funded staff, but it was also very effective. So what did we learn from all these studies? Trying to do these studies and others. Most of the studies that I've been involved with and I've led or co-led in nursing homes have not had highly significant outcomes. And it was not just Interact, but other interventions as well. What are the lessons? So my first lesson is that education is necessary, but it isn't sufficient to change behavior. You can give as many in-services as you want. You won't change provider behavior. It just doesn't happen. So you've got to do other things. You have to have buy-in into leadership. But even if they say they buy in, they have to make it a priority. They have to support it. They have to reinforce it. We had facilities in our trial that in all the facilities, the administrator, director, nursing, and medical director signed a participation agreement, and still that outlined what their commitment was, and they still didn't do it. Champions are necessary for any quality improvement initiative, but you have to be careful. Champions leave and their priorities change. So it's good to train more than one champion. Incentives can make programs work. From nursing assistants to CEOs. We monitoring the intervention fidelity. So one or two of the chains that were involved in our study, a regional quality nurse monitored Interact implementation, and they had better reductions in transfers. But in terms of incentives, financial are the most important. And that's where models like the ISNP come in. And I can talk more about that if you're interested. Programs have to be as simple as possible, but simplicity is not always easy when you're dealing with complex older people who live in nursing homes. We tried to make it simple, but it's not easy. Effective communication is critical within the facility and between facilities. We knew that from the start, and our experience implementing Interact reinforced that. And tools have to be at providers' fingertips. And we've been trying hard, as I said, to embed these tools into point-and-click care. with minimal success. But also you have to avoid over alerting. You don't want to give providers alert fatigue. So when we started using Interact, I knew it wasn't going to stay as paper tools like these, educational tools that were readily visible in a facility, that eventually they need to be put into health information technology. And that's, again, it's not easy, but here is my vision that when a change is noted in a resident, someone, a CNA, a therapist, a housekeeper will fill out a stop and watch online. And that will alert a nurse who may choose to evaluate the change based on one of the Interact care paths or some other guidance. And that evaluation would then be summarized in the computer and pushed to a provider who has a templated order set that they have ready access to. And we have Interact order sets for each of the changes in condition. This can be all automated. Conceptually, it's not complicated. Trying to work with a company that has a million other priorities makes it very complicated. So we're continuing to work with point-click care in order to do this. So I just want to end up with a lesson I feel strongly about person-centered care and quality of life. And the reason I feel strongly about it, and you should feel strongly about it, is this birthday card I was given a long time ago. So conjugating the verb am old, I am old, you am old, he, she, or it am old. We're all old. I've had my nursing home experience. For the women who are listening to this session, you have a 50% chance of spending some time in a nursing home. And for the men, it's 30 or 40% of spending some time in a nursing home. Fortunately, my care was reasonably good. Not everything was good, but it was reasonably good. So we want to improve care. We also want to treat people in a way that improves their quality of life and do it in a person-centered way. And one of the things that we're really concerned about is maintaining function and quality of life, not curing things. So these are residents of the Jewish Home for the Aging, where Sandy and I worked together. We couldn't do research sessions while they were, we had to schedule their research evaluations around their beauty parlor appointments. The average age on this slide is in the low 90s. So they're in their 90s and they're still going to the beauty parlor. And my mother, Mama O, she lived with my wife and I for 3 years before she died. On the left is a picture of her when she was in her early 20s, volunteering in World War II as a health provider in Scranton, Pennsylvania. And she became an LPN and worked as an LPN until she was 90 when she had a stroke. And the picture on the right is her sitting on my back porch in Florida, watching the golf course, very happy. And we took her to the beauty parlor every week or two. So I show this last picture to trainees. This guy is sitting there saying how to diet. He's reading a book, How to Diet. And I tell them, I want person-centered care. So if you're my healthcare provider, when I am 90, if I live that long, and I ask you if I can eat a hot dog, you say yes, and you'll adjust my medication. Okay, because you can't always go by evidence-based protocols. And so you got to keep your eye on the ball. Hey, Sandy. So any questions or questions in the chat or live questions?
I have a couple for you, Joe, that has come up often when we've done this kind of work or similar work. One is beyond the advanced care planning documents, which I also highly recommend and support. What is some other general guidance about how to have effective conversations with family members when you have family who are insistent about a hospital transfer? We hear that a lot, where the family notices a clinical change and they're resistant to the idea that it can be managed within the facility, and they worry, they really push the staff to send their relative to the hospital.
Yeah, it's a great question. So some of the insights I give you, this always comes up, and just based on my 40 years of experience, which most of which was at the Jewish home in Los Angeles. But so the first thing is, what do they understand is happening? If someone has end-stage Parkinson's disease and is repeatedly aspirating and getting pneumonia, do they understand that that's just going to keep happening? That that's just part of the disease? Do they understand? So do they understand the the disease process, and that there's a lot of discomfort involved in care that's futile because it's going to happen again? So that's one important factor. The second thing is to ask the family, what do they expect to happen? Is there expectation that if their family member gets sick, they'll go to the hospital and get poked and prodded? Or would they prefer comfort care and not being relocated? When I've done that, when I've asked families, what is it that you expect? They haven't thought about it. And if you can get them to agree to comfort care, then you can go over in detail what comfort care means. So that's a second thing. The third thing is that I'm paternalistic about it. So the way I look at these conversations is, a lot of times I'm dealing with a 50-something-year-old woman or 60-something-year-old woman or man, and they're not health professionals. They don't know what's going on, and a lot of doctors force them to make the decision. What decision would you make? Well, it's your decision. Tell me what it is. I don't do that, and especially if they ask me. But even if they don't ask me, I say, this is what I would do for my mother or father. And it's what I did for my mother and father, actually, now. And I tell them, this is what I would do for my own parents. And so some people believe that's paternalistic. I don't. Because 20, 30 years from now, instead of feeling guilty about making the decision that they let their parent die, they would say, well, Dr. Ouslander recommended this, and this is what he did for their family members. And then I talk to them about what specific advanced care directives mean. Like, that's one of the problems with the POST and the POST and the MOST, is they have the choices, but I don't think people really understand them. So I tell them, if the issue is feeding, I tell them that dying from dehydration is comfortable. I think every patient that I've seen that has just stopped eating has not really become uncomfortable unless they have a respiratory problem. And the other thing I talked to them is about resuscitation. And I'm just brutal. I tell them, if you have somebody who's 90 pounds, 90 years old, and you're going to resuscitate them, you're going to break their ribs. And the best outcome is they're going to end up on a respirator in a lot of pain, and they're not going to be any better, and probably worse. And in nursing homes, there is data that show that the survivability of routine CPR is zero. It's close to zero. So those are the things that I do, or I recommend doing. So I'm more paternalistic and transparent with people. And I try not to beat around the bush, because I've seen CPR done in the nursing home, and I've done it. And it's even in the hospital, it's not so good. Oh, the other thing is you have to recognize, why is the family doing this? So I go over root cause analyses every week with providers. And the most unbelievably sick and impaired people, their families insist on sending them to the hospital. Why are they doing that? Well, I think there are two possible, other than not understanding, there's two possible other motivations. One could be religious beliefs. And in that case, if somebody's religious, we get a clergy person to talk to them. The other is money. People get checks, and they cash the checks. Their parent is getting checks from one source or another, and they're cashing the checks and using it. So you have to realize those incentives may be there.
Also, if anyone else has a question, please feel free to ask. If not, I know we're already a little bit over time. So as always, this seminar is being recorded, and I will disseminate it after the fact. But I'll just pause really quickly in case anyone else on the call has an additional question.
You can always send them to me, Isaac, if somebody thinks of something.
Thank you for that offer. Yeah, so folks, if you have a question, follow-up, feel free to shoot them, email them over to me. I'm the one who sends out these calendar invites. So you should all have my email address, and I'd be happy to pass them along to Dr. Ouslander. But if there's no additional questions, I want to thank Dr. Ouslander for presenting today, and not just today, he also presented for us last month. And I really enjoyed today. It was really interesting for me as a non-clinician person to kind of hear about this more, like taking a step back, something that I can just wrap my head around a little more. And I thought it was super interesting. So thank you so much for your time. And
tell Dr. Schnelly I said hello. I'm still swimming.
All right. Thanks, everyone. Take care and have a great day.
Okay, bye.